Welcome to Medical Logistics 101 Shortness of Breath Overview. Today we will be talking about dyspnea or shortness of breath. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold and to explain how clinicians think through these problems in resource-limited settings. Dyspnea defined. Dyspnea just means trouble breathing. It is a symptom, not a diagnosis. It has many causes and most are treatable. Our goal is to figure out which system is responsible. Breathing is normally automatic and change triggers fear. Dyspnea is often of rapid onset and anxiety can certainly magnify the feeling. Systems, think of it broadly in several categories. Lungs, that would be airflow, infection, inflammation, or mechanical issues such as a collapsed lung. Heart, pumping, rhythm, fluid overload such as congestive heart failure. Blood, whole body issues such as oxygen carrying problems, infection, or anemia. Most ER testing is aimed at sorting these out. Lung issues, asthma or COPD flare, pneumonia, viral infections such as bronchitis, pulmonary embolism or blood clot, collapsed lung or pneumothorax, fluid overload, congestive heart failure exacerbation. Clues would be cough, fever, wheezing, crackles, one-sided chest movement, or tracheal deviation in the case of a pneumothorax. Heart issues, congestive heart failure, irregular rhythms, example would be atrial fibrillation. Heart attack, of course. Valve problems with the heart. Clues also would be, for this category, would be swelling in extremities, weight gain, chest discomfort, or orthopnea, which just means increased shortness of breath when you're supine. Blood and whole body causes, anemia, severe infections, metabolic problems. Example of that would be diabetic ketoacidosis. They oftentimes present with a very fast rate of breathing called tachypnea. Anxiety and panic attacks, for me, that's a diagnosis of exclusion after I've ruled out more serious causes. Deconditioned after illness. Think of a history of immobility. A pulmonary embolus should be in your mind. If there's a history of malignancy, you should also think of pulmonary embolus. Blood work is helpful here. Respiratory depressants like opiates, common problem these days. Initial evaluation, oxygen level, pulse oximetry at triage, obviously very rapid, just like checking your blood pressure. Exam, respiratory effort, pattern, breath sounds. Is there wheezing? Is there crackles? May also include arterial blood gases and what's called end-tidal CO2 monitoring, which is just a way of measuring your exhaled CO2 levels to give us an idea are your lungs functioning well at gas exchange. EKG, heart rate, and rhythm. Basic labs, complete blood count, complete metabolic panel, troponin, which is just a blood test we do to assess if there's been injury to the heart, often done as serial troponins, more than one. BNP or brain natriuretic peptide, that is a blood test that's helpful in evaluating if the patient has congestive heart failure, if you have a suspicion of that based on exam and the chest x-ray. And of course, D-dimer, a sensitive but not specific test. There are a number of things that can make it elevated, but the most serious of which would be a blood clot, such as a deep venous thrombosis in your leg or pulmonary embolus in your lungs. Treatments, oxygen, of course, different options for this depending on the patient's history, such as do they have a history of COPD? It could affect what treatment you do with regard to oxygen. Breathing treatments, such as albuterol or Duaneb. Steroids, such as IV Solumedrol. Diuretics, such as IV Lasix. And antibiotics, of course, in the case of pneumonia. Blood thinners, depending if you have a patient with a deep venous thrombosis or even worse, a pulmonary embolus. Narcan if you got respiratory depression from opiates. One issue with Narcan is if these patients present by EMS, oftentimes they will have received Narcan, but unfortunately, some of the opiates have a very long half-life as compared to Narcan, so you may have to do multiple doses of Narcan for those patients. Possibly treating anxiety. Had to be careful with this because they could have other respiratory depressants on board, or they may have a history of something such as sleep apnea, and depressing their respiratory drive would be a very bad idea in that case. Red flags, cyanosis, blue lips, fingertips, sudden shortness of breath, chest pain, fainting or near fainting, trouble speaking in full sentences, coughing up blood. Potential pitfalls, assuming dyspnea is just anxiety, treating with home inhalers without improvement, changes in level of consciousness, example, COPD patients and their CO2 levels. With COPD patients in particular, since their lungs are not functioning appropriately, CO2 levels can rise. And as those levels rise, it can impair their level of consciousness and they can deteriorate rather quickly. Ignoring swelling or recent weight gain. That would certainly be true of congestive heart failure. Foreign bodies in kids, they're not always radiopaque on chest x-ray. An example would be a peanut, perhaps lodged in the kid's right mainstem bronchus area, or an area of their right mainstem bronchus. That's not going to be radiopaque on x-ray, and it may be easy to miss. It will produce obstructive changes on the x-ray over time. Croup, patients must be observed after racemic epinephrine. Racemic epinephrine is one of those drugs. The effects wear off fairly quickly, unlike steroids. So they may have to be observed and potentially may require a second treatment of racemic epinephrine. Not recognizing risk factors for pulmonary embolus, such as recent travel. It could be surgery or malignancy. Delaying care because symptoms come and go. Potential pitfalls. Focusing on oxygen levels instead of the whole picture. Missing, for example, another pitfall would be missing a small apical pneumothorax on a portable chest x-ray done in the ER. These are small pneumothorax up near the top of the lungs, near your clavicle. If you don't look carefully, you can miss them, particularly on a portable chest x-ray. Pulmonary embolism. Pulmonary embolism can be a range in size and effects. So, I always tell patients a large pulmonary embolus is going to produce symptoms. Even if I don't know that it's a pulmonary embolus at that point, a large pulmonary embolus will produce symptoms severe enough that they're going to get a workup that's probably going to find it. But a small pulmonary embolism may produce very minor symptoms, and that would be dangerous in someone where you could attribute falsely symptoms to chronic lung disease, such as COPD. Closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.